I'd like to start off as people approach the microphones just with a question for the group, which is that we've talked a lot today about observational data versus randomized controlled trials. I think one of the recurring themes today with observational data is, I guess, that it's observational. And in particular, I've gotten the sense that complications are often not as well noted in observational data as they might be in a randomized controlled trial, where somebody is, where people are required to fill out certain forms at certain times. So I wonder if I could get both surgeons and radiation oncologists to comment on, again, on what are the uses of observational data versus randomized controlled trials, and particularly some of the, in the context of this session, when some of these technologies have wound up with some complications, how if we had better data, we might have avoided those.
I'll take a crack at it. It's always easiest to go first. So I think that the challenges of observational data are that relate to inferring causation, right? So whether or not the treatment has actually caused the outcome. The challenges of observational data are often related to measurement and whether or not the outcome of interest, in this case toxicity, has been accurately captured, and also other things. But I think that both of these approaches can be very valuable for looking at toxicity. In fact, we're to give a podcast later this week of 2 studies, one a trial from MD Anderson Cancer Center and one an observational study from the state of Michigan, both of which are looking at the acute toxicity of hypofractionated whole breast radiation therapy. And they're being published simultaneously because they complement one another. So the observational data has greater generalizability, the randomized trial data has better causal mechanisms, and so when you put the 2 together, you actually can really be like the blind man and the elephant and feel out different parts. So to me, I think they're complementary sources of information that we need to pursue.
Yeah, from a surgical perspective, I would certainly agree. I think it depends on the data source. A lot of the studies that you heard about were from billing data, where basically a code has to be generated for a complication. And comparing that to medical records, certainly there is undercapture. Some of the surgical databases we've heard about NISQIP today, where they abstract charts and they have a very defined data collection process. So I think even among observational data sources, there probably is some variation. But I would agree with what you said. It probably we need to rely on multiple sources of data.
Vikram?
Vikram, NCI. I would like to hear the panel's opinion about the relative roles, responsibilities, obligations of the government versus the profession in deciding who should be credentialed for what. Now, I work in a part of the NCI which sponsors clinical trials of new radiation technologies. And about 15 years ago, our group decided that if a patient volunteers to participate in a taxpayer-funded trial, that we have the obligation to try and make sure that the people who are going to give that advanced technology have some kind of, have demonstrated a certain amount of skill in implementing that technology. So before a facility can treat a patient on one of these advanced technologies, they are sent a patient-shaped piece of plastic, which they have to radiate and send back to show that they are able to accurately target that to the dose that was required. The bottom line is that depending upon the anatomical site, between 1/3 and 2/3 of the facilities failed that test on the first attempt. Okay, and these are the creme de la creme who actually, many of them are academic institutions that participate in NIH-funded clinical trials. Now, this information has been around for a while, but there is no requirement, by and large, in most states for somebody who implements one of these technologies to actually undergo something like that. And we have this very peculiar situation where so many people were failing these credentialing tests that they are now required to treat patients for X number of months before they're even entitled to ask for one of these phantoms. So people essentially are practicing on patients in order to be able to accurately treat a piece of plastic. So I would like to hear your opinion about what is the responsibility of the profession versus the government in implementing something that, or enforcing something like this. Don't all talk at once.
Jason, you want to?
I think I just got volunteered.
Go ahead.
You know, Vic, you raise a really important point about, I think what you're trying to say here is that clinical trial credentialing can sometimes be more stringent than quality assurance that happens in the real world, routine. And it's an important question to consider as the technologies become much more advanced, especially with proton therapy, where we know that the beam at one institution is not like the beam at another institution, about having our quality standards and our quality assurance and credentialing catch up to that. I don't think that there's an answer to the question. And, you know, traditionally in the medical system, the professions, we're a profession, right? We're all part of a profession, regulate ourselves, but there's a balance, especially when you're dealing with high technology. I'd be very open to that conversation.
Stan, can I ask you a question, a follow-up on that? Because I know in Europe, for instance, there was the Dutch gastric trial involved training of surgeons to do the surgery before they were able to run the trial. Do you think that's something that could be done in the United States for trials that?
Sure. It was done with Sentinel Node, TME, all those had kind of credentialing requirements. You had to watch a movie of the person doing the procedure, submit photographs of the specimen for TME, et cetera. There has been a lot. I mean, I would answer that I think it is our obligation to do that. And if we don't do it, we're not going to like when it's taken
You know, you
out of
mentioned
our
the virtual
hands.
tools that are being developed, but unless somebody enforces them, you know, we don't know that people will actually use them.
I'll just make a quick comment. I think that you know, one of the common questions I'm asked when I practiced in Los Angeles and now in New York is, you know, the patients come in and say, look, who's doing the operation? You know, this is a teaching center. And so the truth of the matter is you saw the learning curves that go into, you know, achieving a negative margin or good sexual function. So those are things that I do entirely. And so then on the flip side, if you're training at that institution, you know, how are you supposed to get experience in terms of robotic assisted surgery? And so I think to your point, and there are others who are more lackadaisical, I think, in terms of how much they let the trainees do. And so that there's tremendous variation. But I think that what's going to happen is, unfortunately, as I think, as Dr. Ashley mentioned, we all recognize that there's a need for this. You know, there's some controversy about the Libby Zion case and whether, you know, the cutback in trainee hours has really led to meaningful improvements in quality, or have there just been more handoffs? But I think it just takes a highly publicized case like that, you know, for regulation to come in and for things to change in the absence of surgeons and or others being more proactive about the quality improvement that needs to take place.
My name's John Gardenier. I have a son who's a general surgery resident. And I was curious on Dr. Ashley's presentation that he did not mention ABSITE scoring as one of the initial credentialing mechanisms for new general surgeons. I was wondering whether or not you consider that has value. It certainly seems to put a lot of pressure on the residents. And whether or not, if it is considered to be effective, if there is any way of adapting that or something like it to be adaptable to advanced technologies.
So the ABSITE, and I think this is true in most specialties, they're not psychometrically designed to distinguish. They're intended kind of as a learning tool. That's program directors, fellowship directors use it to distinguish candidates for sure. But the board would say that develops that test that it's not an exam that you ought to use to distinguish people. It really is to learn the gaps in your knowledge. The certifying exam is the same sort of thing. They set a number based on You know, they fail us the same number of people basically every year. But the exam varies a huge amount in content.
Hi, I'm Gwen Darian from the Cancer Support Community. I actually have tried to figure out how to frame multiple things that I've been thinking about as the day has gone on. I represent the Cancer Support Community on the forum, and I'm a longtime patient advocate and a two-time cancer survivor. And so there are a couple of things that I actually thought Drs. Beckelman and Jogsy, there were two things that you said that both had the framework of shared decision-making and what was given to the patient to make that shared decision-making. So in terms of cost, in terms of transparency, both of which have turned into buzzwords, what is the difference? I don't know what the difference is between cost and how patients make decisions when there is a copay, and how cost and patients make the decision when there's a societal or system cost that they don't necessarily see. So I think that is a really critical, that's a really critical thing to understand, and also to understand that people make decisions along a whole spectrum. So I have friends who would choose not to have a very, very expensive treatment if they thought the cost to society is too much. I have friends who would do anything they could possibly do to stay alive and survive their cancer. So I think that, so that is part of the what is shared with the patient in terms of making patient decisions. And Dr. Jogsy talked about the benefit of radiation with lumpectomy, and the benefit was really in local control. It wasn't in survival. So this is something I'm interested in knowing, and I've been doing breast cancer and many other cancers for many years, how we've looked at the way that we've tracked patients and their decisional regret when you've done radiation, but the outcome hasn't been survival. The outcome has just been local control. And what we found, and what I found through the work that I've done, is that if people feel like they're prepared to make decisions and that there is true shared decision making, there's very little decisional regret. So there are questions and comments, but sort of a frame to put this back into the patient voice.
I think this is a wonderful commentary that you've given us. I think absolutely we must involve patients in shared decision-making and discussion of what outcomes are important to them. So for some, and I will just say there is a modest improvement in survival with breast radiotherapy, yes, but it's modest. But to some patients, they'll say, a 3% improvement in survival for a relatively non-toxic treatment is something they would definitely want. And to another patient, it's a very, very different conversation. And so we have to engage in these discussions with patients. First, I think the first step is actually to decide with the patient the degree to which she wishes to be involved in the discussion. So there's actually been a whole literature on assessing the patient's decision-making preference style. And then once one understands the degree to which the patient wants to be involved in the discussion, then one must ascertain what things matter to her and how much, right? Her own utilities for the decision. And as you mentioned, we do need to bring cost into these discussions in a sensitive way that empower patients and allow them to emphasize the things that they value.
What I often say is what Dr. Jagsy said. It's a common response. I think it's important just to unpack the issue of costs and cancer care. Just unpack it and begin that conversation. And maybe 2 or 3 years ago, we wouldn't really be talking about such a sacred disease such as cancer in the context of costs. And now we're sort of freely discussing and wondering, well, what cost should we really be talking about with patients? So it's important to unpack that. With expensive technologies, proton therapy, I'm an active clinician and focus mostly in men's cancers, and costs have come into the consultation room almost every conversation I have. Insurance companies, out-of-pocket costs, who pays for what does that mean in terms of my choice? I live it every day. My patients live it every day. They talk to me about it, and then they talk to our financial people about it. They get confused in the system. At the same time, we lack the evidence to definitively say this is better than that. So they don't even have something around outcomes that they can hang their hat on. So I think it's simply important to unpack this, to describe both the outcomes that are important to our patients, but also describe the associated costs with those outcomes, and to work with patients to make that decision together as part of participatory decision-making.
Mm-hmm.
There was very nice guidance from ASCO recently around discussing value with patients, value of chemotherapies with patients, and I think we can look to our medical oncology colleagues and say, you know, we live that too.
So can I just make a little follow-up to that?
Yeah.
So we have actually been doing a lot of work around value. We have a cancer experience registry, which currently has 8,000 people on it, and we're actually doing a project with ASCO on value and a project with Duke. So we look at this sort of public, academic, private partnership and looking at that. But I think there are two things. First of all, cost is more than just money, and which we can't ever forget. And I think the other thing is that sometimes we all do things, and I would say advocates do the same thing about protecting the patient. And I think that's where Dr. Jagsi was really, really clear, was that we have to make sure that we understand what people want to know, what they want to be protected from, and what they don't want to be protected from. I think the other issue that is a larger framework, and I'm sorry to take up so much time, I just have been sort of storing up these thoughts all day, is the context of long-term survivors. So I'm in a cohort of a number of people who are young adult cancer survivors who have gotten a second primary cancer that may or may not have had to do with treatment, may or may not, it isn't the same cancer, but I don't have any decisional regret of what I did 20 years ago. Because I feel like I'm an educated patient, and I have so many friends and colleagues in the same situation. So part of this is by having really, really strong doctor-patient communication. But I will say that on the other side of that, I do not feel as if the system was prepared to follow me or any of my colleagues in the way that we should have been to keep up to date with the credentialing, with the continuing education. And so I think that there's so many facets to this conversation, and there's so many ways where so much of what we're talking about, these words, we have to take back the meaning of these words. Value is a really important word, but it has become a little bit of jargon. Innovation is an incredibly important word. It has become jargon. Quality is an incredibly important word. It's become jargon. So I'd like, as we're thinking about talking about this within a context, I'd like to really reclaim these words and make sure that we have all of the stakeholders at the table to really talk about what it means to them.
I just wanted to add that ASCO's value framework is actually in an open public comment period right now, and I think it would be extraordinarily valuable for folks in this room to comment on that framework, because it's something that they're actively developing.
So thank you, all of you, for this wonderful end to the day. And you all have touched upon the complexity of encouraging adoption or not encouraging inappropriate adoption. But I wonder how are we going to measure success from an intervention to encourage adoption or in adoption? Will that require, for example, an NIH CCDR randomized trial of certain places that adopt or do not adopt? You know, how do we, the response to these potential interventions are so complicated. How are we going to move forward in 20 years after we've put into place Dr. Beckelman and Dr. Jagsi's ideas nationally?
So another part of this discussion is what we use as our evidentiary standard. So what I mean by that is in randomized trials, we try to be fairly certain that the result that's shown is the real result. But when you're dealing with policy interventions to guide system change. You can do it sort of in that framework, which uses a pretty high level of statistical significance, or you can relax the evidentiary standards. And NICE in the UK relaxes their evidentiary standards in order to come up with a recommendation on how to use technology when and for whom. So that's a discussion that if we relax the standards, we'll innovate faster, but we'll make more errors as we innovate. But in the context of system change, rather than individual patient change, in the context of system change, that's probably better than what we do now, which is like a pre-post study, right? We saw a lot of them up here, actually, because it's the best we have. It's, all of a sudden the intervention happened here and look at the line, right? But that doesn't explain all the other things that are happening in the world that might explain that line. So by relaxing evidentiary standards, by using almost techniques that might be consistent with business process improvement, I actually think that we can innovate on, not to overuse the word, but innovate on several techniques over time to quickly understand what actually impacts de-adoption or what impacts adoption, and make decisions, in a matter of years rather than decades. That would be my hope.
I'm going to ask Jason to comment on this. We heard earlier Dr. Whalen's talk about rectal surgery and the use of robotics, and you've shown some nice data that in the GYN oncology and in benign, perhaps that there's no advantage for the robot. And one of the things that I oftentimes hear the vendor say, and you've probably heard this as well, is the robot a way to convert all of these open hysterectomies to minimally invasive? Because even though I think you obviously have a great skill set in terms of laparoscopy, but I think a lot of people in surgery know that sometimes you either have it or you don't when it comes to pure laparoscopic skills.
I think this is definitely an issue that GYN is struggling with. I think, certainly as residents are finishing now, many residents aren't trained in laparoscopy, so I think that will certainly widen the gap. I think until there is change in reimbursement policy, that you'll continue to see uptake of robotic surgery, and I think that's really probably the only thing that's going to slow down adoption in GYN. And for many things, for many of the GYN cancers, I think it's almost analogous to prostate cancer, where the horse is out of the barn at this point. And you saw that over 60% of minimally invasive hysterectomies are robotic at this point.
But I wanted to follow up on this idea of the evidence that suggests that in some cases robotic surgery is equivalent to other techniques, and therefore we shouldn't use robotic surgery. The challenge in our system, though, is that if they're equivalent, that means they lead to similar outcomes. And I don't really mind that at certain institutions they've done a randomized trial, but continue to use the other technique because it's equivalent. Because frankly, the payment system allows them to. And so I don't think that I wonder the extent to which we should be thinking about how to, again, link the evidence to payment, rather than, for a physician who might be more comfortable with the robot, they're getting equivalent outcomes. We have a third-party payer, might as well just use it, that's okay, right? It's equivalent outcomes, the evidence shows, right? So I think one of the key things we've identified here, but it's not new, is that the link is severed. Right? We have all this evidence, but whether it gets into payment policy is a different issue.
If there are no other questions, I think you get the last word, Dr. Beckman.
Wow.
Okay.
That's awesome.
So I think that talking to Tina, we're not going to do any additional wrap-ups today. I think it's great audience participation, people sticking here the whole day on very interesting, complex topics, but I learned a lot. And we are now off to, I'm looking at Tina and she's going to nod and say it's time for a reception. Okay, thank you, everybody.